So again, welcome, and we'll just start with some housekeeping and brief reminders. And if it's your first time, welcome. If you have been a longtime member of the community, welcome. Anyone in between, welcome. We're very fortunate to have Dr. Michael Doherty, who's going to give the didactic on epilepsy and dementia, and then Dr. Sylvia Russo will give a case presentation. Thank you both. So please enter your names of all the folks who are with you in the chat, and remember to mute your microphone when you're not speaking, and then unmute and say your name. Please turn on your video if you can, and we understand if you can't, of course, but we'd love to see each other in this virtual space if possible. A reminder again of a number of echoes that are ongoing, including one for traumatic brain injury, one for psychiatry and addiction, a telebehavioral series, as you see here. There's also a telephone consultation available for complex pain management issues, particularly for high-dose opioid use and deprescribing. You see the 844 number here. And there are also CME accredited case conference series called the Telepain series, which is on Wednesdays. Please always protect PHI, so no identifying information during any of the presentations. Remember that each of our sessions are recorded and available through the website. And please do take the time to complete the 1-minute post-session survey. And we really do read all the comments, and we want to make this useful and helpful to everyone in the community. So we value your input and feedback and thoughts and comments. Again, if you're interested in the Dementia Friends rack cards, then enter your name in the chat and we can mail them to your office and clinic. And this is just a really wonderful program that can help to build dementia-friendly communities through trainings, and just a really wonderful resource that is growing. Here are some upcoming didactics. The next one is by Dr. Tatiana Sadek on care transitions. And you see here we have a wide range of topics that will be featured in the next months. Again, as always, we really invite you to contribute by bringing your cases forward. And we learn from each case, every case. And the presenter, I think, also by kind of thinking about things and also soliciting input from the community learns as well. So please do bring those cases. We're CME and CNE accredited. As you see, here's our School of Medicine CME accreditation. We have no financial relationships to disclose, and were there ever any, they would all be mitigated and disclosed. But in this case, we have none. Neither the planners nor the speakers have any relevant financial relationships. So here's our hub team, as you see, which is represented throughout throughout Washington. It's really a lovely collaboration across institutions. And then as you see here, also across the state. And we've provided over 1,000 instructional hours, and over 70% of survey respondents have said that they would incorporate a practice change based on the learnings. And we really are, appreciate you spreading the word as well, since word of mouth can help build community and strengthen dementia-capable care throughout the state. So without further ado, I would like to invite Dr. Michael Doherty, who is the Medical Director of Swedish Epilepsy Center, to speak to us today on epilepsy and dementia. Thanks so much, Mike.
Thanks, Nancy. Bear with me a second. Can you let me know? You can see my screen in the presentation mode.
Yep, looks great.
Okay, so thank you for inviting me to speak, Nancy, and for your Project Echo team. I'm honored to be asked to speak about this topic. We are often asked to see elderly patients and demented patients with seizures. And in working on this talk, it forced me to go back and look at the literature and assess it as a more mature provider in terms of being doing this for over 20 years now. What does the literature actually tell us that might help shape my practice and perhaps yours too? The first slide you may have seen before, it's in many epilepsy talks. It's basically an incidence of epilepsy across an age range. And you can see that there are basically a U shape to that or J shape to that curve with the early childhood incidence and then a later incidence. And we'll be concentrating obviously on the later incidence. But you can see also that the older you get, the more likely you are to have seizures. And in the literature and studying reasons for the onset of seizures towards the older age range, you can see in at least this paper from 2010, 2011, that in the epilepsy risk factors down below here, in the second half of the chart, that you see vascular as the main one driving that incidence curve. But everything else is fairly symmetric, perhaps excepting that there's not much of a history of early onset febrile seizures and an older onset epilepsy. What you'll not see here is risk factors specifically of dementia, which struck me as interesting because the literature on epilepsy and dementia is a little thin, frankly. It's mostly divided into age-related epilepsy, not necessarily dementia risks for epilepsy. So there's a weakness in our literature in studying this, which I didn't appreciate as much until I started digging into this. However, the age-related literature for older patients is still useful in thinking about your patients that you're seeing who might be having seizures. And on the right-hand side of the screen, they divided older and younger patients. Older patients in this case, in this paper, in this series, is older than age 55, younger is less than 55. And certain types of seizure are more common the older you get, and some are less common the older you get. And the ones that are more common, in this case, they've labeled as dialeptic, although that term is now out of date. Dialeptic means reduced responsivity or awareness and amnesia to the event. Other terms you might be familiar with or might have heard for this are complex partial seizures, and that terminology is out of date too since 2017. So now it's termed focal onset with impaired awareness. And focal onset just meaning that one part of the brain triggers the onset of the seizures. Automotor might be another term you're not familiar with. That's one where patients show what are called automatisms. It's worth writing this word down if you've never heard it before. But automatisms are what we see in temporal lobe and inferior frontal lobe seizures, where patients have repetitive picking behaviors or pausing behaviors in which they're plucking at something over and over and over again. That if you've never seen it before in association with epilepsy, you might have seen it in the exam room or on the wards, even in some of the patients who are undergoing a temporal lobe seizure. They can look very confused and have a repetitive behavior that's hard to ask them to quit because their brain is basically having a focal seizure at that time. Down below, though, the type of seizure that most of us get nightmares about is generalized tonic-clonic or convulsive seizures. And the interesting thing there is that the convulsive seizure activity or generalized tonic-clonic is much more likely in younger patients and much less likely in older patients. Doesn't mean it's not impossible, but it's more common to see a confused, long duration epoch of activity rather than a convulsive seizure the older you get. So if you're thinking that seizure in dementia patients is going to be convulsive or grand mal presentations, it's not the way to think of it. It's going to be long duration, confused epochs, possibly with fumbling or picking behaviors. This is old data too, but it gives you a brief breakdown in how the difference between older and younger patients might look in terms of seizure types. The older you are, the more stereotyped your seizure is going to be. The seizure frequency tends to be lower. In general, the post-seizure state tends to be longer with confusion than it does in younger people. The potential for injury is higher because of falls. The causes for the seizures are generally lower with vascular. I would add dementia illness and tumor as being some of the common causes the older you are. The response to what here is labeled as AEDs, meaning anti-epileptic drugs or anti-seizure medications, for older patients generally is quite good in comparison to our harder to treat younger patients. But tolerance to those medicines tends to be really poor. I'm going to jump to the next slide. What about Alzheimer's and epilepsy? Is there a bidirectional risk? In more recent work, it's thought that later onset epilepsy, 10% of it might be due to neurodegenerative causes. So if you get asked on an exam, the 10% answer is generally pretty good for Alzheimer's and epilepsy comorbidities, schizophrenia and epilepsy, autism and epilepsy. 10% is a reasonable board kind of response to that question. Most other older onset epilepsies are vascular related from decreases in blood flow and ischemic issues. We know that from our epilepsy patients where we take hippocampal tissue on block for resective treatment of refractory epilepsy, if you stain it and look for amyloid and tau deposits, you can see that. And the longer duration of seizures you have, the more likely you might see deposition of amyloid and tau. Is there a bidirectional risk? And I would suggest there could well be, in part because the seizures that you have in a temporal lobe patient that are hard to treat tend to accumulate damage within the hippocampus and cause memory problems over time. And we know that in our younger patients with temporal lobe epilepsy, if you don't have their seizures well controlled, you can watch their verbal and nonverbal memory scores basically decline the more refractory they are, paralleling in many ways what you would see in a progressing Alzheimer patient. However, if you have memory issues from Alzheimer's disease and seizures that are occurring out of the temporal lobe, your acceleration in your memory decline is going to be much faster. So the older you are with temporal lobe phenomena to your seizures or temporal lobe onsets, the more likely you'll have disability or inabilities to use language and non-language memory abilities. It turns out the associative neuropsych testing that requires a lot more concentration in left and right hemisphere connection, like trail making tests where you follow the trail that's on the printed piece of paper with your pencil. That's harder the more white matter damage you have, implying that the connectivity in older patients between hemispheres may also be what drives some of the decline in cognition, not just from seizure activity. So white matter we don't think of as typically pro-seizure-genic. We think of the gray matter as more likely to generate seizure. But if whatever is driving a dementing illness is eating away at your white matter, your gray matter becomes an island. It can't communicate to other gray matter areas, and that accelerates memory decline. Perhaps intuitively, the more anti-seizure meds you use, the more likely that your cognitive performance declines, because many of those meds come at a cost of sedation or concentration. We'll talk more about medication choices based on what's been written in a few minutes. So in Alzheimer patients specifically, seizures are often non-motor, subtle, long, focal onset impaired awareness. Sometimes they may have myoclonus as a common feature, often in younger onset Alzheimer patients than older. Often there's no obvious trigger to their seizures. When we see people in clinic, we're always looking for triggers for the seizure. Were they up all night? Did they just get back from a long flight to Europe? Had they been drinking a lot? Had they been just put on Wellbutrin? Those would be some classic risks for provoking seizures in our patients. So in Alzheimer patients, there may be a sizable chunk of them who have no obvious definable provocation to their event. The risk for epilepsy in this group is reported to be better established using longer duration EEGs. So normally when you order an EEG to an outpatient lab like ours here, they'll run about a 40-minute study to an hour, depending on how much time you request them to run it for. And in that kind of study, you are sampling a limited amount of time, and there's a really good chance you're not going to pick much up on that other than in an Alzheimer patient, what we call a generalized slowing. However, if you strap EEG wires on and send them out for 72-hour study, which is called an ambulatory EEG, you might pick up more clues or risks from that EEG study about an ongoing high-risk epilepsy state. We use the EEG not necessarily to capture seizures. We're thrilled when we do because it makes the diagnosis very easy. But more often the case, we use the EEG to look for subtle abnormalities called sharps or spikes. And those give us a risk factor or risk determination of likely seizure risk potential if we see those. So that's what we're looking for on the EEG is sharp waves and spikes, and those are easier to pick up with longer duration studies. In Down's patients, as you probably all know, Down syndrome accelerates Alzheimer based on the APP genes. And about 84% of those patients are reported to have seizure, although I would argue we certainly don't see that in our clinic, and it may be due to a referral bias, frankly. And again, from more subtle changes, and perhaps I wonder a little bit about whether some of the data on Downs is a tiny bit out of date, because a lot of our Downs patients that we do see seem to be doing really well with memory well into their 40s and 50s in ways that the literature suggests they should be doing much worse. Maybe we could talk about it at the end if other people have different views on that, but I don't see 84% of my Downs patients with seizures. Again, if you have seizures that are deriving from tissue that you're using from memory, untreated, that will hasten cognitive decline. We talked a little bit about human tissue showing tau and beta deposition in mouse models. You can see it as well. You could wonder, does amyloid beta contribute to epilepsy in Alzheimer patients? It turns out in Braak staging of temporal lobe, about 94% from the literature show hyperphosphorylated tau. We aren't typically doing our hippocampal stagings with Braak pathologies. We're just looking at hippocampal dropout and neuronal numbers and things like that. So we don't formally stage using Braak criteria for our epilepsy patients undergoing temporal resection. Vossel et al. In Lancet Neurology was suggesting that epilepsy should be looked for in Alzheimer patients if they have fluctuations in cognition, rapid progression in cognitive decline, early onset Alzheimer's disease, and myoclonus. Those would be some red flags about who really does need to be looked at closely. I would argue that when we see myoclonus in older patients, we're also thinking about paraneoplastic issues, particularly if it mimics that rapid progression, age around 50, cognitive decline. That's in the differential, and it's an important one to look for is paraneoplastic evaluation. So hippocampal atrophy, I mean, you see it all the time. In Alzheimer's disease, we see it all the time in temporal lobe epilepsy of long-standing duration. But there's other disorders that can trigger hippocampal atrophy. So encephalitis, particularly the herpes families, the herpes simplex encephalitis often has disproportionate damage to the temporal lobe. And Nancy, correct me if I'm wrong, but there's been some literature on herpes virus in Alzheimer's disease, I think, in terms of possibly being a risk factor for later development. But it makes you wonder if some of the smoldering herpetic cold sore or other versions might be some risk factors that we overlook in our patients long term. The other one is paraneoplastic encephalitis. We'll see hippocampal atrophy there as well. So the hippocampus becomes such a target for seizure activity. Seizures are electrical disturbances where hundreds of thousands of neurons are misfiring and can't contain a charge on their cell membrane effectively. And the more glucose a cell generally consumes and uses, the easier it's going to be to disrupt its ability to correctly hold a charge and regulate that charge. So the hippocampus is really where we spend a lot of our time focusing or looking at seizure activity, because that's the area in our brain that tends to use the most glucose and therefore is the easiest to upset electrically. The brains of all of us, I mean, if we did MRI scans on all of us on this meeting today, there's a really good chance that many of us would have what are described by the radiologist as very small hippocampi. It doesn't necessarily mean that you have a dementing illness. You can have normal variability in the size of the hippocampi. It's always a hard one to explain to a patient who you know is cognitively normal what their 1% hippocampi compared to normals means. And when I talk about 1%, at least here at Swedish, in our epilepsy scans, we'll ask them to do what are called hippocampal volumetrics, where they do measure the hippocampal volumes and give you a size assessment. You can follow that prospectively over time and see how it's changed over time. So I'm sure that UW has a similar protocol. I don't know if everyone's using an MRI screening, looking or requesting for hippocampal volumes, but it is something you can sometimes use to get a sense if a patient is complaining of memory dysfunction, particularly if it's a more lateralized memory dysfunction where their word-based and language-based memory seems worse than their visual or geographic memory. So word-based or language, meaning most likely left hippocampal map, or geographic-based, more likely to be a right hippocampal. So that's what we're looking on the ambulatory sharp waves and spikes. I will add that a lot of programs will farm out ambulatory EEG to external readers where you don't necessarily know the readers and their experience. And I've definitely found that EEGs done in ambulatory programs or ambulatory predominant services are often overread, meaning that there have inconsistencies called that perhaps really aren't there. And what I mean by that is we spend a ton of time looking at EEG and trying to understand with a video correlation, why does the brainwave look weird? And we can use that video correlation to make sure someone's not brushing their teeth or combing their hair or scratching their head, all of which can look identical to a seizure, which the ambulatory EEG does a much poorer job at because the video often doesn't work or synchronize. So it is prone to overcall, so you want to be careful with that. Epilepsy meds and dementia. There's obviously, when you look at the available epilepsy meds to use for seizure control, it's a very intimidating list. There's lots of them. They all have weird side effects. Some are idiosyncratic, but all of them have dose responsive similarities. The higher the dose, the more likely you are to get sedated, confused, clumsy, and have double vision. Some, though, have very specific side effects that can mimic dementia or pseudodementia. One of them that you'll see used very frequently in this population is levetiracetam or Keppra. Many of you probably have patients on that and probably have prescribed it. We'll talk about that one more later and how to get around some of those issues. As you get higher on many of these meds, the sedation issues start to limit participation and attention, those being two key factors to start coding a memory of any sort. If you can't concentrate and focus, you're not going to make a memory. Some of them are prone to triggering insomnia. And as we know, we tend to code and store our memories during deeper stages of sleep. So if you ruin your sleep staging by using meds that provoke insomnia and limit sleep hours, two of them being lamotrigine or Lamictal, or zonisamide or Zonagram's the other name for it, those ones can sometimes hurt memory formation over time. And many of our anti-seizure meds are dirty. They have drug-drug interactions that are significant and annoying and hard. Two of the more common ones there would be valproic acid or Depakote and phenobarbital. The next issues that I run into that are worth keeping in mind, they're typically not super provocative, but many of our drugs in trying to stabilize cell membranes from salts that are moving in and out of the cell membranes, particularly sodium channel blocking meds like Dilantin and Vimpat and Tegretol and oxcarbazepine. Those sodium channel slowing functions those medicines have the same effect on slowing sodium channel in the other main electrical organ in our body, meaning the heart. So if you're using drugs that block sodium channels, there can be sometimes some unanticipated consequences to heart functions and heart conductivity. So there needs to be a little bit of caution there. If you've got someone with AV block or intracardiac conduction delays, some of our meds are not necessarily great calls. Then there's these very specific side effects for two meds, namely zonisamide and topiramate, that can cause word finding difficulties and word recall. So topiramate's used often in headaches, definitely in seizure control, definitely used for weight loss. Those two are notorious for making people feel dumber or slower or less articulate. It doesn't mean you can't use them. Often those side effects are dose responsive. Those side effects tend to be less noted in people whose IQs are lower. Folks who are very sharp and very high in IQ definitely notice this almost right off the bat at any dose. Any seizure med, though, at a higher dose can cause those feelings that you can't recall the words you want to use. So you can imagine how tricky that gets to add in one of these anti-seizure meds to your patient population who's already complaining of word finding difficulties. And then ask them, are you having problems with word finding? You almost know what they're going to say. They're saying, absolutely, that's why I'm seeing you, doctor. So if you want to try and minimize that added effect, these two might be two drugs to try not to use a whole lot. What are some of the upsides? Well, correctly treated, temporal onset seizures may diminish further memory decline or may make cumulative issues with memory decline due to seizures less likely. Put in another way, we know the more seizures you have, if they're coming from the temporal lobe, the more likely your memory is going to suffer. Treating it might preserve some of those functions longer. We see this in our long-standing temporal lobe seizure patients. The ones who have low seizure frequencies don't show progressive memory, hippocampal atrophy on the MRI, whereas the ones who do have lots of undertreated seizures do show memory. Hippocampal atrophy progress. We also know that when we use the implanted brain stimulator, the RNS or NeuroPace device in temporal lobe seizure patients, when it's correctly treating seizures and aborting them in a manner similar to, say, a defibrillator shocking someone out of a malignant heart rhythm, the RNS device does that for our seizure patients. It shocks their zone of seizure generation out of the potential of developing a seizure. When we see that well trained and working, the cognitive neuropsych outcomes there are actually much better than the medication-based treatment. So stimulator-based treatment there for temporal lobe seizure can show memory betterment over time. Many of our meds for seizure control have some mood stabilizing effects, and two of them that are most prominent, and you may have used both of these, would be valproic acid or Depakote and Lamictal. And some of them have mild sedative effects, which frankly can be useful, particularly if behaviors are disruptive or hard for caregivers. And phenobarb is one that sometimes we'll use in Alzheimer patients with that in mind, that a touch of sedative now and then can be actually quite useful in mood stabilization, particularly if it's a long-acting drug that doesn't fluctuate much in med levels. And then there are some that are really much better at myoclonus than others. Levetiracetam, zonisamide, valproic acid are three. This study was looking at three of the more commonly prescribed medicines for older adults with cognitive impairment. And basically, it was looking at capro or levetiracetam, lamictal or lamotrigine, and gabapentin or neurontin. And basically, it's saying that the tolerability of each of those, it's a reasonably standard adult dose, was good to excellent, with the efficacies also in that group good to excellent. And they were not listing cognitive side effects, although again, I would preface that it sort of depends on your degree of sophistication and how hard you're asking. It's pretty easy to have cognitive effects for any of these meds at high doses. You can read through some of the adverse effects there. What we typically notice in our center with each of these meds, the adverse effects of levetiracetam are behavioral and mood-based, often with mood depression, not necessarily paranoid agitation or anything like that, but more of a depressed mood. Lamotrigine, the common issues that bother our patients are insomnia and drug rash. The drug rash is probably the #1 reason we stop it, other than being perhaps not as strong as we'd hoped in seizure prevention. Lamotrigine is a slow to titrate drug. It's one that does alert people a little bit. And if you are prone to anxiety, it can sharpen the anxiety and make it much harder, and to the point of even being obsessive or compulsive, or even having tic-like behaviors. So if you've already got a very anxious patient, lamotrigine isn't necessarily your best choice. Gabapentin, that one I run into issues with peripheral edema and fatigue and weight gain very predictably with weight gain at higher doses. It's not a very strong anti-seizure medicine. But again, in this population, Alzheimer or demented patient population, sometimes you don't need a very strong anti-seizure medicine, and gabapentin can be a very good choice for an infrequent, relatively mild epilepsy. In studying who sticks with the drug once they're started with it, there are retention rates studied on levetiracetam or Keppra, lamotrigine, and phenobarb. And what's interesting about this study is that even though these meds had differing response rates, the retention rate was actually pretty good on each of them. Depending on how you define it, retention rate is often who's still on it at 2 or 3 months once you start it. And normally in our adult patients, none of our drugs have a retention rate above about 75%. So the implication here is you can either get away with the medicines better because they don't complain about it as much, or they're just better responding to it because you're using lower doses in general than you might in an otherwise more aggressive epilepsy in a younger patient. And I found this really interesting. There weren't significant differences in the profile of intolerance side effects when they studied this. I would have thought phenobarb would have made people super tired and intolerable. This one, lamotrigine, again, the insomnia, and levetiracetam, the mood issues. But in general, there weren't significant differences in side effects for those three. When they studied cognitive performance with those same medicines, the only one that actually showed betterment in cognitive performance in this trial was levetiracetam or Keppra. The lamotrigine and phenobarb didn't show cognitive improvements. However, there's other trials where lamotrigine does show improvements in recognition and naming tasks. What to say? This study was just looking at performance differences. It's basically summarizing that last point, that the levetiracetam improve performances, whereas in certain subscores on the Stroop naming subscale, these are neuropsychological testing. I might just skip over this slide because it just kind of reinforces what we were just talking about. So I'm going to pivot a little bit and maybe turn this around to ask for your help. What am I doing in my practice to help minimize Alzheimer or memory decline long term? So I've started over the last 3 years spending way more time on this and just counseling patients on what it is they should be doing to preserve what they have long term, understanding that by age 85, they may be looking at up to a 1 in 3 risk of Alzheimer's disease. So I've been spending an enormous amount of time
Mike, we can't. Wait, you sound muted. Sorry, something. It looked like you're muted.
Yeah, I can't hear him either.
You said we've been spending an inordinate amount of time and then we kind of lost you. No, I can't hear it. Let's see.
How
Working.
about
Put in the
Yeah.
chat that he's working.
Yeah, there you go.
okay, so sorry, I just unplugged and plugged back in. My
No
apologies.
worries.
So
Thank you.
I spend, hopefully you guys could look through so I didn't have to read this laundry list, and hopefully you could see this is probably similar to your auto-imported memory advice for your patients, but these are some of the things I spend talking with my patients about, all of them, including their families, about how to lower risks of memory decline. And I pulled some of this from Nancy's talks and from popular press and for literature reviews and so forth, but that's generally what I'm telling folks when they ask us, because they ask us all the time, I feel like my memory is getting worse. These are all kinds of epilepsy patients. What do I do about it? And the sad refrain is always, well, there's very little that's going to make you better, but we're going to look for things that can definitely make you worse, and we're going to try and moderate those and make those less likely to worsen your memory decline. So that's what I spend time talking with people about, independent of the med side effects. What should I be doing to determine contribution from Alzheimer's disease? So this is not part of my practice, and I don't really do workups looking for Alzheimer's disease. Are there diagnostic tests I'm missing? Should I be running CSF studies? Or I don't put this into my practice, and I wonder whether I'm missing an opportunity here to work that up. So I wonder maybe towards the end, people could contribute that ask of you. Are there things that I'm missing here that I could probably be doing better? And then I wanted to end on just the take home for providers. There's a few things that I really do like using quite frequently. The first is, especially if they're on a known irritant to folate levels. So Depakote, we know, changes folate metabolism and folate levels. So does phenobarb, Topamax, and phenytoin. Is I like making sure that they're on the methylated versions of B12 and folate together. It turns out a lot of our patients in the epilepsy world have one of those mutations or less efficient in processing off the MTHFR gene. And I know a lot of people have some skepticism about that, but I have learned that it's an easy trial, it's low risk, and the number of people who've come back and said my concentration and mood and focus are better is rather astonishing on that. So rather than just going straight to a B group multivite, I prefer my folks to go to the methyl version instead and skip over any chance that they might have in problems methylating. This one also, and it doesn't matter if it's this company versus another company, but a little bit of B6 sometimes helps with Keppra moodiness. The second is if you're going to use the Keppra or levetiracetam, please skip the short-acting version. Go straight to the long-acting version. It's a generic. It's easily got at this point. About 5 years ago, there was some shortages, but this one is easily obtained. And the longer the version, the smoother the level over 24 hours. And a smooth level translates to less contribution of the drug driving mood and intolerance issues. So I don't use the short acting unless a patient explicitly tells me they do fine on it. I jump to this one because I don't want people getting divorced. I don't want people angry at me. And it is a big difference in whether or not they tolerate this drug. And if you start it off the bat, you're less likely to have them coming in complaining about mood and other issues. It is a renally dosed drug, though, so you want to be a little careful if someone has renal insufficiencies, which is really the next point. You don't need high doses typically, and you may need lower doses over time. So this is not a fixed choice where you start them at age 75 at 1,000 twice a day of an anti-seizure med, but they still need that at age 85. They may need a much lower dose. So checking drug levels and understanding, am I pushing this too high? Might I get away with a slightly lower dose? And if I wanted to try a lower dose, what's my backup plan if they revert to having more seizures? Are they prepared to use an emergency medicine like lorazepam? Are they ready for the risk of lowering meds for more seizures? And if they're not, if they're quite okay with the dose and the irritations and indignities of being on an anti-seizure med, if it's not really that bothersome to them, I don't typically mess with the dose. So that's pretty much all I wanted to cover. I'm sorry about that glitch on the audio there. I'm glad it worked out though.
Yeah.
Are there questions or ideas?
Thank you so much, Dr. Doherty. What an awesome talk. Great broad range and some really practical pearls, as you say. I see that Carrie has a question. Carrie, are you able to unmute, or do you want me to read it? Either way.
Yeah. Hi. Thank you so much for this great talk. I learned a lot just listening. Question is, especially as we take care of folks in the kind of palliative care space, if we're moving towards end of life, or if people just say like, I was put on this med, but I haven't had a seizure in 15 years, and you're worried about side effects. Like, what's your approach to deprescribing?
Yeah, so in general, I am not a fan of deprescribing anti-seizure meds in palliative circumstances, because the last thing I want to see is my patient seething as their last act on this earth, this sort of thing. It just can be extraordinarily traumatic. On the other hand, like I was saying before, a lot of the common meds, especially the ones we were emphasizing there, you can look at drug levels and use that to gauge, might we get away with a much lower dose? But in general, I know palliative and say in a geriatric service, often they will try to winnow down non-essential meds and even start backing off things like blood pressure meds and so forth. But the palliative approach I typically use is to leave folks on it if possible. If there's side effects and fatigue is among them, maybe lower them, but I don't tend to withdraw them.
Thank you. Thanks again, Mike, for that great presentation. And we're now going to switch gears, and Dr. Sylvia Russo is going to share a case with us, and she's a cognitive neurologist from Sacred Heart, part of Providence in Spokane. Thank you so much, Sylvia.
Thank you again for the opportunity to present this case to you. Let me go ahead and share this. So it's an unusual case, at least for me. I don't usually see these cases involved so much with legal issues, but my goal for presenting this is how to best support the family through this, kind of let them know, even if there's nothing we can do to solve the legal issues, we're still here and we're helping you through this. And if the audience has had an experience with similar cases, I would love to hear about it. So just briefly, the history of present illness, this patient presents in advanced stages for me, presented around the fall of 2022. She's a 70-year-old right-handed female. Timeline was difficult to establish because the main caregiver was the partner who is the alleged abuser, and the daughter at that time was undergoing treatment, advanced treatment for breast cancer herself, and so she couldn't be involved as fully as she would have wanted. And so the daughter and the sister who lives in on the East Coast were there trying to give me as much history as possible. What I could gather is the onset was approximately in 2018, possibly earlier than that. And she started having difficulties with praxis-related tasks. For example, not knowing what to do when she had to put gas in the car, or not knowing what to do when having to put things in the fridge. And then she sometimes would take objects from other people thinking that they were hers, but they didn't belong to her. And later, 2019, 2020, there started being more word-finding difficulties, more trouble expressing herself. And in 2020, her daughter was finally done with kind of her cancer treatments and started getting more involved and started noticing, oh, mom is forgetting a lot. And she would be getting lost on her doctor's visits, the doctor that she had been seeing for many years. At that time, a SLUMS score, and I don't have the sub scores for this, but her daughter was 11 out of 30, so quite impaired already. And what they started to notice is that her partner seemed less attentive to her, reluctant to have her evaluated. There may have been allegations that her partner may have been violent to her and neglecting her care and probably giving her too much medications to keep her calm. And these medications, we still don't have any proof or evidence of this, but it might have included opioids, for example. Fast forward to the past 2 to 3 years, and there seems to have been a more rapid progression. And in March of 2022, this patient was admitted to memory care, had a hard time adapting. They have a house call PCP who tried to do their best, trying to keep her calm, started olanzapine, started valproic acid, which caused some side effects. And at that time, her SLUMS score declined to 1 out of 30, started having trouble expressing herself more and more, recognizing familiar people. And so I see her at this stage. Not a whole lot in terms of past medical history, other than this history of kind of binge drinking every once in a while in the past. And due to kind of body dysmorphia issues, unfortunately. She's a high school graduate. She was very successful in kind of working for the US Post Office, retired at 55, not related to cognitive issues, and then still did some works on the side. There's a family history of dementia. Both her parents had a late onset dementia, seemed to be Alzheimer's due to predominant memory issues, some psych issues in one of the brothers. Maternal aunt also had dementia, but the details are really unclear per her family. Exam, again, very limited. This is a person in advanced stages. She had kind of a word salad, had trouble expressing herself. And I suspect this was kind of the main barrier, limiting assessment of other functions, which seemed to be affected. Her facial expressions were a little bit decreased. Her gait was a little bit slow, but there was no other frank Parkinsonism appendicularly. And this is her MRI. So I'll show you a T2 flare and axial orientation. And what I could see here, this is done at age 70, so in 2022, and there seems to be some hippocampal atrophy here, and kind of periopercular atrophy, perisylvian atrophy, some atrophy a little bit in the frontal lobes as well in the parietal lobes, and there is a moderate degree of white matter, flare hyperintensities that I could see. I'm going to play that again for you. And so a little bit of white matter disease here, possibly attributed to kind of chronic microangiopathic disease. I'm also showing you the SWAN sequences. They're a little bit motion degraded, but you'll see that in the supratentorial space, there is a couple of microhemorrhages, more in lobar distribution, more in superficial distribution. And I think she meets modified Boston criteria for probable cerebral amyloid angiopathy based on the appearance and the location of these microbleeds. And so once I move forward, so what transpired later is that there is an ongoing investigation against this patient's partner on him allegedly having caused a similar cognitive and general decline in a lot of women. There is at least 2 other previous partners of this guy who started off fine, no problems, and within 5 years or 3 years of being romantically engaged with him, start developing memory problems, and they all get placed in memory care, and they're very advanced, cannot provide the history. And so a detective came to my clinic telling me this and telling me he was worried because now this patient, this alleged criminal is starting a romantic relation with yet another woman, and they're trying to prevent any harm if there is harm to be prevented. And so they asked me, have you ever seen this in your practice of a person repeatedly doing this to many people and causing Alzheimer's to them? And I was very perplexed, saying, not really, but this seems unusual that there is this pattern of behavior. The sister seemed to have had a conversation on the phone with the patient years ago, saying that he was trying to strangle her. And there were a lot of questions for me saying, could poisoning have caused this? Apparently, one of the victims or suspected victims of this person had elevated mercury levels in the blood. So we try to do everything to try and help her and validate the daughter's concerns that seem legitimate based on this additional history that transpires. This former partner seems to be walking into the memory care demanding to be a little bit more controlling of her medications. At one point, he slips something out of an unnamed or unlabeled bottle to her that makes her feel way worse. This kind of makes him banned from the memory center, and the daughter now gets full guardianship. But the main issue is that the partner, the ex-partner, is still the main person as a beneficiary of one of the patient's life insurance policies. And apparently that would be a lot of money. And there is a repetitive behavior of this guy having himself as the main POA and getting the life insurance policy benefits from the other alleged victims too. So it seems like a pattern, but it's hard to prove anything. There's a detective involved and working on this. From a medical perspective, I tried to kind of deal with the behavioral issues a little bit better. We got her off the valproic acid, we got her off of the Zyprexa, put her on some Lexapro, which seemed to have made her a little bit more awake, a little bit more interactive, but still advanced. We're trying to see if she would tolerate donepezil, although she's in advanced stages, and so it's hard to really gauge how much benefit that would have. In the suspicion of a probable cerebral amyloid angiopathy, we took her off of aspirin together with her cardiologist. In the interim, she got diagnosed with diastolic heart failure. So the issue remains could there be a heavy metal poisoning that could have accelerated this process? And so the caveat is that the tests that the daughter initiated on her own are done several months, almost a year after the partner was last in contact with the patient. And so some of the heavy metals, if they were there, might have not been reflective in terms of levels. And so this is a hair, and the top you see a hair evaluation for toxic and essential elements. This is something the daughter kind of went out of her way to do on her own, just because it's really hard to take the patient anywhere. And so this was done at the facility. And I spoke with the poison control of the state of Washington. They really had no specific input on all of this up top. Since there was a concern as to mercury exposure, we did a 24-hour urine test of mercury. That seems to be the more accurate months after the exposure, because it can still be cleared and expelled by the kidneys, and she doesn't have any renal failure. So it still shows as negative. But the comment on this Mayo Clinic test seemed interesting, that there was a lot of arsenic detected as one of the ancillary tests that they do. And so there is now an arsenic test pending. And so you can see how complicated this gets to untangle. In the literature, there's just, circumstantial studies on arsenic and mercury and other heavy elements kind of causing oxidative stress and mitochondrial damage, and therefore theoretically accelerating the disease course of Alzheimer's. If there were allegedly strangling of the patient, could that white matter disease, could those microhemorrhages derive from a watershed injury? Based on the pattern and location of those white matter changes, my straight answer is unlikely, because they don't look to be in a watershed pattern, rather more of a periventricular pattern like you would see in good old-fashioned vascular disease. My conclusion is that this is an early onset Alzheimer's disease with vascular contributions and a probable cerebral amyloid angiopathy, potentially made worse by abuse. But whether this patient was intentionally poisoned, I am having a hard time answering. At the same time, the suspicion seems legitimate. So I'm curious to see what your thoughts and advice would be on this, and I appreciate any input you would have. Thank you.
Thank you, Sylvia. Wow, what a tragic and challenging, brutal case that you're describing. Thank you for bringing that to our community, and I'd like to hear from anyone in the community, any questions or comments, or have any of you encountered a similar instance? I mean, I think the case presented last time around capacity is to some degree related, but not, of course, to this extent, and not with the issue of possible serial abuse. So does anyone in the group have any questions or comments for Sylvia?
Hi, so I'm Carrie Rubenstein. I am a geriatrician at Swedish, but I also sit on the King County elder abuse multidisciplinary team. So first of all, thank you for bringing this case, rising the issue of elder abuse and mistreatment sort of to everyone's forefront of everyone's mind, because it's so important. And I basically agree with sort of your assessment. I think a really careful history of the course of her cognitive and functional decline that went along with this partner's involvement in her life would be useful, as much as you can get. The serial nature of this is super scary, and most likely, I think you're right. This is a person, he was targeting people who were more vulnerable, and this person was more vulnerable, And absolutely, like, we know delirium accelerates dementia. And so all the things he did, and we don't know what we may never know what they are, probably did accelerate, but proving that's going to be very, very challenging. So I don't have a ton to add other than just like, thank you so much for bringing this to the community.
Thanks, Carrie.
I
Yeah.
appreciate it. And so, yeah, my ignorance is that I am not a toxicology expert. And I call the Washington State Poison Control, which is, again, the daughter prompted me because the primary doctor was kind of done with them. And so I just called and I said, this is not your usual request of a child swallowing pills, but can you please help me? And so it's just hard to put it in context of they're really focused on this poisoning issue. But I said if there were a toxicology expert that works from a medical legal perspective that could kind of tell us afterlife, would a liver biopsy be indicated, or other important examinations that we cannot do in a living person, would that have any impact? And so it's just hard because we're in Spokane and there may not be a ton of people kind of devoted to this. But yeah, I think it's important because, before coming here, it wasn't under my radar. And it now is. And I think it's important to kind of listen to them, even if it seems like a very strange thing that mercury could cause all of this, but still there seemed to have been abuse. It's not just your usual abuse where the person just gets neglected or the caregiver just suffers burnout themselves. It seems to be more of an intentional bad thing that happened to her. So it's good to have the reassurance I'm not missing a key piece or anything that I could be doing for them right now, and that's not happening in some way,
I imagine that everyone in the community, I'm certainly feeling reassured that the daughter is guardian and that he's no longer accessing her in the memory care facility. And so he can't perpetrate further.
Yeah, he was banned the moment he slipped whatever it was. It was a drink, and they thought it might have contained drugs in it, and because she immediately changed behavior that afternoon, and so at least that he's banned. We changed her MyChart access, we changed her passwords and everything. But still, it was scary because when I saw her first, this guy was calling the clinic and he was saying, well, we should do this and we should do that and yada, yada. But thankfully that part is over now.
Mm-hmm. And then in terms of, I don't know if the daughter is, did she have capacity at the time that she designated him as financial POA? It's going to be very hard to elucidate that.
I don't know. Yeah, because it happened in the past. The only data that we have is that slum score of 11 out of 30, which again, I was taught never to consider a slum score or a MoCA score as, she has dementia, because that doesn't really make a distinction, but at least it's a piece of evidence. And so the detective has access to all of that. He requested all the chart. And so at least that information is there for them to work with. But yeah, it's hard because now the alleged suspect was in Hawaii with the first partner, then was another partner in Washington. There's this partner in Washington, and now there's a partner in California that he is currently engaged with, doing apparently the same thing. But since we are across state lines, the detective here with the Spokane police cannot necessarily call anything in California unless he has exorbitant evidence, is what I understand, not working in the field, but it seems hard to kind of prove anything, and I want to help them, but at the same time it's an impossible conundrum because I'm seeing them, and all she says about that period when she can have a little bit of clarity is like, things were not good. That's all she says. And her daughter to my surprise, started having her go through therapy. I don't know how she can go through therapy, not being able to speak, but it seems like she was able to say something, that something was very bad and something was traumatic in very general terms. So I appreciate your input. I know this was kind of a borderline case where not a lot can be done, but at least I know that this group of people, there is nothing else that would be done other than what's already been done. So I did this again, pushed by the daughter, saying, yes, you have my permission to discuss everything, but at least she has the extra reassurance that with a group of experts, we are on the right track as much as we can for her, and of course keeping her calm and stable from medical perspective. We're still working on that.
Yeah, and raising awareness of this really important critical issue for vulnerable elders.
Yeah.
So thank you. There's a couple of questions in the chat, and then Nicole, were you raising your hand? Or
oh yeah, it's okay. Actually, Nancy, your comment was exactly what I was going to ask about, just exploring her capacity at the time that she signed documents and adding him to her life insurance. I was just curious about that.
Yeah, and it may be really hard to go back. It sounds like you've done a lot of sleuthing, and it's just hard to piece together that natural history and progression. Barbara, do you want to unmute yourself, or do you want me to ask your question?
No, I just did. I was making noise, so I turned myself off again. So I just had I just saw that the uranium level in that urine was pretty high too, and it's like, wow, that's sort of scary. And it is down on the list that it's associated with some memory loss, and it just makes you wonder why, where she lived, and or was he working in such a place? And not to downplay the whole mercury thing, but it does. It just is another area of question in my mind. And no, I agree with what everyone said. It's like how vulnerable these women are is something we really have to focus on. But I just wondered about that. Thank you.
You're welcome. No, thank you. I appreciate it. Yeah, those were hair levels, and the same question you had raised in my mind, saying, it depends, in Washington, there's radon, for example, and we all have to mind about that. But is this an environmental exposure? Apparently arsenic as well can come from the environment, and we may all have it, but there is an organic form and an inorganic form, and the inorganic form is the bad one. The organic form, whatever, is the one that we're all exposed to, doesn't really hurt us. And so it's hard to kind of pick one of these and say, oh, that's the one. And the Poison Control Center wasn't particularly shocked by these values. I read them to them one by one. We stayed on the phone for 40 minutes a couple of weeks ago. And it's just interesting because it's like you can grasp it, but then it just slips away, But thank you again. I will definitely look into that with them as well.
The family is so fortunate to have you as their fierce advocate and their compassionate care, doctor, really. I have sometimes reached out to occupational medicine. I don't know if there's occupational medicine in Spokane. I mean, I understand this is not an occupational exposure, but they have a lot of depth of understanding in sort of chemical exposure and what to make of it and how to interpret a 24-hour urine collection. I mean, the Mayo probably also does have that understanding. Maureen, did you want to unmute yourself? And then Mary Beth?
I was just going to comment that, when I've had cases that I felt where my expertise was pretty limited, and that of local resources also limited, I've reached out very successfully to authors of papers on the subject, and I've been impressed with how responsive they've been, and had conversations, and so that's another avenue, because I do agree that the Poison Control Center is probably more interested in acute poisonings. So it was just a thought.
Yeah, no, that's definitely a good thought. And then yes, the heart failure, they also were very concerned because she was very healthy, doesn't even have hypertension, you know. Why does she develop a diastolic heart failure? Her ventricular thickness is really high and her ejection fraction was something like 70%, which is weird. And so arsenic can cause cardiovascular disease. And so it causes heart failure in general. That's what they say in the papers. But yeah, I mean, reaching out to the corresponding author of the papers that I found may lead to some clarity as to what type of heart failure and what have you seen in your patients that you've seen with this. So yeah, thank you for that. And I think
Kara, I think Mary Beth's question was responded, but if there's another question, Mary Beth, that you have, and then Kara, and that'll be our last question because we're kind of coming upon the half.
I don't have any other questions, but this is such a challenging case, and I agree you've done so much already. And even just thinking outside the box and reaching out to this team, but I think you've done a lot. So
I appreciate it. Thank you.
And Kara?
Hi there. I'm wondering if any of the other women are still alive that have interacted with this man.
Yeah, so I think the first one, I'm not sure if they're still alive. I think one of the two is dead. And the other one is still alive in a memory care, same situation as her, cannot speak, cannot say anything. It's like she has Alzheimer's. You know, from my perspective, when I saw her first, not knowing the whole background, they were just asking a lot of questions on heavy metals, like some patients do. And I just thought to myself, weird. But to me, not knowing the story behind, I was just, unfortunately, this is early onset Alzheimer's disease with vascular and CAA, which is sad. She has family history, mother and father, so maybe she had two ApoE4 genes that just accelerated it in the setting of whatever happened to her. But then the whole pattern of behavior with this guy came out, and that's just not normal if that truly is the case. So yeah, the one woman who died, I don't know if they did autopsy on her. The detective didn't go into too much detail with that. But the other one is just in the same boat as her, cannot say anything. They just found elevated mercury in whatever test they did in the urine or the blood or whatever it was.
Right. And it's the pattern that's so scary.
Yeah. Yeah.
And since the others were out of state, so I'm wondering if it needs to be a different law enforcement agency that's involved,
Right.
like the FBI, where they actually have more
Yeah.
they have more testing and more resources available for them that can actually investigate further. It sounds like you've done as much as you can do,
Right.
and it's very time consuming.
It
So
is.
is it time to, you know, again, involve a different law enforcement agency that actually can look at the different scenarios and put those pieces together?
Yeah. Yeah, I mean, the daughter kind of messages me almost every month about this, and I will probably bring that up to her. I'm not sure the rules of how much like evidence you need. To me, that's pretty convincing, but at the same time, like how do you demonstrate that sort of behavior happened? So
Right. And it sounds like the law enforcement people that you have been working with already are suspecting a pattern.
yes.
So I don't know that it needs to be proven at this point, just the
Right.
suspicion surrounding it, and then
Yeah.
again, defer it to them to do further investigation.
Mhm.
If they did autopsies, they should have samples, hopefully
Yeah.
saved that hopefully they could do testing on, just to see if the patterns of exposure are similar.
Right. Yeah, that's a very good thought. Thank you.
Thank you so much. And we are now at 1:31. So we're a minute over. Karen, thank you for mentioning. So if if things do come back elevated, perhaps exploring some alternate ways of clearing the exposure. And then Mary Beth's recommending, people can see in the chat, but I'll just read aloud, is there utility for biomarker studies in the CSF or other studies? And please do take the time to fill out the 1 minute after session survey, and then we'll see you in a couple of weeks for Tatiana Sadek's talk. Thank you again, and thanks again for the wonderful case, Dr. Russo, and thanks everybody.
And I'm reading all the comments. Thank